Clinical communication criterion C4, information gathering, is where experienced international medical graduates suffer the most surprising score collapses. Most doctors assume that C4 is the one area of the exam where their real-world clinical experience gives them an automatic advantage. They believe that taking a thorough, exhaustive medical history is what examiners are looking for. That is a fatal misunderstanding of the test dynamics. In real-world hospital medicine, thoroughness protects you against clinical error and litigation, but in a 5-minute OET roleplay, attempting to conduct a comprehensive 15-minute hospital admission history triggers what we call the defensive medicine trap. You end up treating the roleplay like a medical board examination, rather than a timed communication test. When you prioritize an exhaustive diagnostic checklist over the mechanics of the clock, history taken bleeds past 3 minutes, your diagnostic trajectory turns into an interrogation, and you fail criterion C4. In this video, I am going to decode the two major information gathering hazards that cause doctors to run out of time, and project the exact verbatim mechanisms you need to execute targeted exclusion and the directed diagnostic pivot. The most frequent information gathering failure is the defensive medicine trap. When candidates enter stage 2, they panic about missing a potential differential diagnosis. Instead of focusing on the specific parameters outlined on their candidate card, they launch a rapid-fire interrogation, firing unconnected, closed questions at the patient without signposting or context. Observe the live acoustic intercept on your screen as a candidate executes a checklist interrogation.
How long have you had this headache? Is it throbbing or sharp? On a scale of 1 to 10, how severe is it? Does it radiate to your neck? Are you experiencing any nausea, any vomiting, any sensitivity to light? Have you had any fever or chills?
Analyze what just happened. In less than 40 seconds, the candidate fired 8 consecutive rapid-fire questions at an anxious patient. Look at the acoustics of that exchange. There are no transitional bridges, no signposts, and zero clinical pacing. The patient feels like they are being cross-examined in a courtroom rather than evaluated by a consultant. More importantly, half of those questions were completely irrelevant to the specific management task required on the roleplay card. The candidate burned their diagnostic runway asking defensive questions, leaving themselves backed into a corner on the clock. Passing criterion C4 requires executing targeted exclusion. In the 5-minute consultation masterclass, your goal in stage 2 is not to run an exhaustive medical workup. Your goal is to extract only the specific clinical data points required to safely unlock stage 3 management before the timer hits 3 minutes. To gather this data without sounding like an interrogator, you deploy signposted clustering. You explicitly group your diagnostic questions into logical, transparent categories. Analyze the structural architecture of this masterclass alternative.
Mr. Davies, to help us pinpoint the precise cause of these headaches, I need to ask some targeted questions regarding the nature of the pain itself, followed by a few quick checks for any associated symptoms. To begin with, how would you describe the pain and when did you first notice it starting?
Look at the mechanics of that transition. You signposted the diagnostic framework, some targeted questions. You outlined the agenda before asking, the nature of the pain, followed by associated symptoms. You started with a focused open question to let the patient summarize the core issue. You gathered the exact clinical data needed, the patient felt guided rather than interrogated, and you maintained absolute control over the diagnostic velocity. The second major C4 failure occurs when candidates encounter an anxious, talkative, or stressed patient who begins rambling about non-clinical detours. We call this unchained narrative wandering. When a patient starts describing personal, work, or lifestyle stress, candidates often lose their diagnostic focus. Fearing they will lose marks for empathy, they allow the patient to talk uninterrupted for 45 seconds about non-essential background details. Listen to this failing execution.
I see, Mr. Davies. So your boss has been putting a lot of pressure on you at the office lately? Tell me more about how long that workplace stress has been going on.
Look at the clock. It is 2 minutes and 45 seconds into a 5-minute role play, and the doctor is opening up an unchained narrative loop about workplace dynamics 3 years ago. By inviting the patient to expand on non essential background stories late in stage 2, the candidate guarantees a timeline collapse. History taking will spill past 3 minutes, management will be ruined, and you will lose marks across both C3 and C4. To stop narrative wandering without appearing cold or dismissive, you execute the Directed Diagnostic Pivot. You validate the patient's concern in a single concise phrase, link it directly to clinical safety, and use a closed diagnostic question to pull the conversation back onto your card's trajectory. Analyze the pacing and precision of this masterclass correction.
I completely hear what you are saying about the pressure at work, Mr. Davies, and work stress can certainly play a role here. However, to ensure there are no immediate physical red flags driving these symptoms today, I need to ask specifically, have you experienced any sudden dizziness, blurred vision, or weakness in your arms?
Look at what was accomplished in under 17 seconds. You validated the stress factor. I completely hear what you were saying. Work stress can play a role. You justified interrupting the narrative using clinical necessity to ensure there are no immediate physical red flags. You re-established diagnostic control with a targeted multi-system red flag check: dizziness, blurred vision, or weakness. The narrative detour is instantly closed. You protected the patient's safety, gathered critical diagnostic exclusions, and preserved your 3-minute hard ceiling. Information gathering in OET medicine is not an exhaustive medical fishing expedition. It is a surgical, signposted data extraction performed under strict temporal limits. If your history taking consistently bleeds past the 3-minute mark, or if you feel like you are interrogating your patients just to cover your candidate card, your consultation layout is leaking seconds. Do not wait for exam day to discover that your diagnostic pacing is failing. Click the link in the description below to run my free timeline integrity audit. This interactive diagnostic tool will calculate your exact risk of a structural collapse and show you precisely where your layout is failing. Run the audit, lock in your structural boundaries, and I will see you in the next video as we decode the final communication pillar, criterion C5, information giving.